Without further ado, just a very simple case presentation. 55-year-old gentleman with a 2.5 centimeter mass. He's otherwise healthy. It's grown from 1.5 to 2.5 over a 2-year period. Mark, why don't you get started with us?
Thank you very much. Thank you to the Focal Therapy Society for the invitation to speak this morning. So my task is to convince you that active surveillance is the right move for this patient that Dr. Jarrett just described. So anyone who manages kidney cancer or manages small renal masses in particular knows that this is really a balancing act. And what are we balancing? We're balancing multiple competing risk factors. The risk of procedural risk, oncologic risk, renal functional decline, and quality of life risk. So what I'll do is I'll go through each of these 4 domains, and I have a score sheet here, and we'll see how well active surveillance stacks up against surgery or ablation. So why don't we start with procedural risk? Now, I know in this audience, complication rates are very low, but we've all heard of colleagues elsewhere who do have complications, and this is data from NISQIP looking at complications of surgical outcomes of radical and partial nephrectomy. And they just have any complication here, but 15 to 20% any complication rate, and still double-digit major complication rates after these procedures. Complications from surgery, we're all aware of. Hemorrhage is the most common, urine leak closely after, and injury to adjacent structures. This happens to be a UPJ stricture after a medial kind of hilar partial nephrectomy. The procedural risk for ablation is also not insubstantial. So the overall complication rate in one series, a meta-analysis, was 11% with major complications in sort of the 3 to 7% range for ablations, and slightly more for surgical or laparoscopic ablations than percutaneous, and similar between modalities. So again, not benign. What is the procedural complication rate for, here, just a few examples. So similar pneumothorax is on the list, of course, for ablations, but you can get urine leaks, you can get hemorrhage. All of these and the rates from the previous slide from that, the citation at the bottom of the slide there. What are the procedural risks from active surveillance? No procedural risk, right? These patients can keep calm and carry on. So I think in the domain of strictly procedural risks, the ACE goes to active surveillance. But let's get into the meat of the argument here, oncologic risks. Now, when we talk about oncological risk, there's really 2 flavors, and kidney cancer patients with small renal masses are subject to both overtreatment and undertreatment. Well, overtreatment, why is that? That's a problem. Well, we've already heard that 20 to 30% of nephrectomies in this country, in this study, are for benign renal masses, for oncocytomas, for AMLs, and what have you. And we don't do enough biopsies or other imaging studies to rule these out beforehand. So this is 30% of patients who undergo surgery really don't need it. And the same is likely true for ablation, particularly if we're not doing staged biopsies, which we've already discussed. Let's look at some ablation-specific oncologic outcomes, and I'll blow this up just a little bit. The risk of local failure is not insignificant for ablation. In this study, 5% of ablations needed a repeat ablation with a 10% local tumor progression rate and a almost 2% metastatic progression rate. And you can see in the figure on the upper right here, a small sort of rim, an enhancing nodule at the edge of a previous ablation site. And these are all with kind of minimum follow-up, less than 2-year follow-up. Now, despite that, we do know that RCC-specific survival for small renal masses really is excellent across the board. And so if I can draw your attention to the 5 years RCC-specific survival, really 95 to 98% for either percutaneous ablation, partial nephrectomy, or radical nephrectomy. So given that, how does active surveillance stack up? Well, this is data from the DISARM registry, multi-institutional registry, looking at both overall and cancer-specific survival. Cancer-specific survival is not even a figure here because it was 100% at 5 years in this data. Overall survival was down to 75%. Why is that? That's because these were patients with competing comorbidities who succumbed to non-kidney cancer reasons, so a well-selected group, I would say. What's more is that for patients who have a period of active surveillance, we actually have access to the best biomarker we have for kidney cancer outside of tissue, and that is growth rates. So here are two studies that were published almost simultaneously, one from Tony Finelli and the group at Princess Margaret looking at growth rates for various RCC histologies. And they found there were differences. The clear cells grew faster, the papillaries and chromophobes sort of intermediately, and then pap type 1 at a low rate. Around the same time, we at the NCI showed similar outcomes for patients with genetically defined tumors. So patients who harbor a BAP1 mutation, which is associated with high-grade, high-stage, low-survival clear cell RCC, had fast-growing tumors. Your run-of-the-mill VHL-driven clear cell, sort of intermediate, and your MET-driven papillaries and folliculin-driven chromophobes at a low growth rate. So this period of active surveillance, we can actually learn about the tumor biology, even in the absence of biopsy. Now, I would also say that nothing lasts forever, and active surveillance doesn't last forever either. And many patients who choose active surveillance do go on to have delayed intervention. But we have good data that show that a period of active surveillance does not compromise future nephron-sparing procedures. These patients can still have partials, they can still have ablations, even active after a period of AS, and it does not compromise cancer-specific survival if you compare primary intervention versus delayed intervention. So again, oncologically, active surveillance gets the ace. What about renal functional outcomes? Well, we know that a quarter of patients with a T1 renal mass have pre-existing CKD. And after surgery, a not insignificant number go on to have worsening CKD. So 2/3 of patients with a radical nephrectomy and 1/5 after a partial nephrectomy have mild CKD. A third of radical nephrectomy patients, 5% of partials, have moderate CKD. There aren't great data for active surveillance or really long-term data for ablations either, but here are two papers that look across the board, and we see that looking at GFR change, cryos, not much, losing maybe 3 GFR, but really nothing for active surveillance. Really, we're not harming these patients' kidney function, as you might imagine. And that's from Danzig et al., the same from Layton et al. Under it. We're really not impacting kidney function with active surveillance. So once again, the ace goes to active surveillance. And I'll end with this, quality of life outcomes. And this is maybe the biggest argument against active surveillance. Why would I want to do nothing if I have cancer in my body, doc? Well, this is, again, a study from the Disarm Registry looking at the mental component summary of the SF-12, looking at both baseline and then yearly out to 5 years for patients who have a primary intervention versus active surveillance. And no differences in the mental health component, and actually the mental health component increased with time, meaning that patients became more comfortable. 4 ACEs, all to active surveillance. So I'll end with this. This is a quote from Mark Twain. Success is a journey, not a destination. It requires constant effort, vigilance, and reevaluation. And I really say the same thing about active surveillance. This is not, we follow these patients closely, and we can intervene at any time without harming them. Thank you for your attention.
Thank you very much. We'll take some questions at the end to talk about the surgical approaches. Dr. Shuch.
Okay, thanks, TJ. Okay, so this was a pretty easy task, and I appreciate the softball. So basically, we have a lot of options for the management of small renal masses. And clearly, the NCCN guidelines, does have partial nephrectomy. They have ablation. And on this, there's a little asterisk. Ablation could mean cryo. It could mean RFA. It actually, in recent years, it's also said it could include stereotactic radiation. And there was actually a submission from our radiation oncology colleagues to say it needs to be separate, but ablative techniques could include that as well. Not discussed today, but active surveillance as well. Now, this patient has a couple options. When you have a patient who has a renal mass, gold standard based on the NCCN is still partial partial nephrectomy. Well, this patient has, we've described, they started on active surveillance. It was 1.5 centimeters, and clearly they have started to progress. They are really meeting our characteristics of failing active surveillance. And you can go two ways. So this patient is clearly 55. They've really shown that this tumor is going to grow. And you could choose either to move forward to the gold standard, a partial nephrectomy, or give them an ablation. And I think we have a clear kind of winner here, and I'll understand why. Active surveillance is not watchful waiting. And if we put a patient on active surveillance we know we could treat, we have to make that clear. And the modalities now, they don't always have to include surgery. And I could tell you that, I've had patients too sick for a haircut and they still could tolerate radiation to their, tumor. I've had patients progress to metastatic disease on active surveillance. And again, if you continue watching them, you don't know when they're going to have an MI, maybe when they're going to have surgery. And then it's a year or two later, they come and they're, past the chance of salvage. So this is data from the Disarm registry where you have to make it clear that some patients are going to cross over, and most of these patients cross over due to growth. Now, this is not a fair fight, and I would say that partial nephrectomy here is clearly, going to be the champion here. And this patient, if you look at a growth rate, this is what you'd see when you track them. Most renal tumors don't have what's called a saltatory, growth rate, which is something we describe in our CNS hemangioblastomas. Mark and I probably see a lot of those patients with VHL, where the tumor may grow and then may stay stable for many years and then start growing again. Most renal tumors, they have a decent linear rate of growth. They don't just stop for like 3 years and start growing again. If they exhibit growth early, usually they're going to continue to grow. And then you're going here, which is called the danger zone, 5 millimeters or or greater. There have been patients who've had metastatic disease that have, had tumors less than 3 or 4 centimeters. And if you look back, some of those patients were ones that may have had a negative scan and then 2 years later have a 2.5 centimeter renal mass. Clearly that tumor is something that's growing at a quicker rate than you'd assess. So this is really in the danger zone here. And I would make a point that while many small renal masses may be benign and not need treatment, many do. And adverse pathological characteristics can occur in small renal masses. And we had a study of, a couple hundred patients less than 4 centimeters. There are high-grade tumors. There are T3 tumors. There are tumors with sarcomadoid, rhabdoid, high-grade lymphovascular invasion. So while benign tumors can grow, most of these fast growers or sharks are going to be enriched for bad tumors. Now, this is from my good friend and co-fellow, Eric Kaufman at Roswell, where he really put a large number of patients on active surveillance. And they really had defined thresholds to actually progress towards treatment. And he had a nice cohort of 123 patients where about 20 or so, about 30 progressed towards needing delayed intervention. And if you look at the growth rate of these and then look at the histology, none of these tumors which progressed on surveillance at the time of a partial nephrectomy were benign. And and the majority of them were either T3 or they were grade 3 and 4. Now, these are probably tumors that were born bad. We shouldn't ignore that they're born bad. There are tumors with bad biology, and this patient clearly has a more aggressive disease biology, needs to be treated. Now, clearly there's different flavors of kidney cancer. We have, we have our sea cucumbers all the way to the sharks. And biology basically dictates aggressivity. And we are soon going to have tools available, including, our new PET CT scan, which is going to the FDA very soon, which is going to diagnose some of these hypoxic tumors, some of these clear cell tumors with CA9. But growth kinetics right now are our best way to assess tumor biology other than a biopsy, and we're not doing genomic profiling on a lot of these tumors. I would argue that it probably is not as important as growth kinetics. Now, we should really match treatment intensity to tumor biology. And some tumors require aggressive treatment. And when we're trying to assess metrics for this 55-year-old patient, we have a lot of tools that are available. A 55-year-old patient is going to have, the average patient, the average Joe, like this 55-year-old patient, is going to have 27 years of life expectancy ahead. Do we want to potentially worry that we watched the tumor maybe too long and then have them have a metastasis later? Do we want to give them an inferior treatment that can have either local or distant progression that they can't be salvaged? I would argue no. We can look up the characteristics. There's a NISQIP database where you can put in your patient's characteristics. A 55-year-old guy, a little overweight, on hypertensive meds, has some systemic signs of disease, ASA score 1. Their median hospital stay is a day and a half after partial nephrectomy, and their complications are going to be low. Death, 1 in 500, okay? That's very acceptable. Most of those are medical causes. What about readmissions? Going to be very low, 2 or 3%. So I think we can say that with a partial nephrectomy, these patients are going to have a pretty good outcome. Now, what about renal functional outcomes? Most patients, looking at the distribution of GFRs on the MDRD equation, most of our patients who are age 55 are going to have a GFR of 70 to 85. They can tolerate a little hit to their kidney. Probably they're not going to tolerate a good hit if they need a radical nephrectomy. If you do an ablation, it fails, and you may need to do a salvage radical. If you wait and watch that 2.5 centimeter tumor on the next scan, when they come back a year and a half later and it's 4.2 and there's segmental vein invasion, get it now. This patient's going to need treatment. And I would say a modern partial nephrectomy with the nucleative techniques, we can maximally spare almost all the parenchyma. And there's a good series looking at a tumor nucleation series with our good friend Gopal Gupta at Loyola, where most of the nephrons are preserved. Ablation with a wide kill zone does kill a lot of adjacent parenchyma, and a lot of patients can lose 5 or 10%. I have a patient with VHL who's on dialysis after 15 ablations because all that normal kidney tissue got killed. I removed 10 tumors last week. The patient's GFR did not really change significantly. That was a Berthog-Dubé patient, but they managed to maintain most of their tumor, most of their kidney volume. Finally, convalescence. Most of these patients are going to get back full recovery within 4 to 8 weeks. Most patients want to get back to work. Most patients still want to have a job. Okay, most patients in our country, most people have FMLA capabilities. Within 12 weeks, they can take medical leave. And this is a nice series from Andrew Wagner and the Beth Israel team where they look at convalescence. There's a 27-point recovery validated instrument. And between 4 to 8 weeks, most of our patients after partial nephrectomy get back to their baseline. Most patients want to get back very quickly, and I don't think getting back within 2 weeks long-term after an ablation versus 4 or 6 weeks is really going to be that significant. Finally, oncological efficacy. This is unmatched. Patients, we try to compare, we try to do propensity scores. These are different patients. It's going to be very, very hard to show a randomized trial that one is better than the other. But you cannot argue that local recurrence is much higher with an ablation. Salvage is sometimes challenging because you can't always retreat. And patients sometimes want to know what was in their body, and you don't know that with the biopsy. So I'll just say that aggressive tumors need aggressive biology. Partial nephrectomy kind of wins out on all these metrics. And I think it was pretty easy to say that partial nephrectomy is the right approach. Thank you.
Thank you. And now, Dr. Cadeddu for ablation.
Thank you. And I've been doing ablations in the kidney for 20 years plus, and this might be the first time in my career I get to go last. I'm always the butt of the joke, and at this meeting, I appreciate the ability to go last because I can rebut my colleagues here. And it's never get a chance to do that. So ablation, we're now dealing with a 2.5 centimeter mass, and I would say the ablation at this point is preferred. So in 2023, we can't ignore that the guidelines first endorse. This patient meets the guideline criteria, less than 3 centimeter tumor. I'm going to take the privilege of saying there's no adjacent structures that are critical that could risk injury. And just for completeness, the guidelines do recognize that even over 3 centimeters in kidney tumors, we can do and offer patients ablation, as we heard when Dr. Jarrett talked about even with cryoablation for larger tumors. So it's very easy for me because the guidelines clearly endorse that thermoablation is clearly an alternative treatment now to surgery. It's taken me 20 years to see this statement in the guidelines, and it brings me satisfaction that we have to offer and discuss for this type of patient that thermoablation by percutaneous approach is the way to go. So why the emphasis on size? Just to review the literature, why does the guideline say less than 3 centimeters? And that's because in the thermal ablations, the heat sink phenomenon is important. And the larger the tumor, the more vascular, the likely that you might have an incomplete ablation. So the first paper using RF came from our institution a decade ago. And in patients between 2 or less than 2.5 to 3 centimeters. The ideal patient is this. One treatment, we can get a single ablation into the high 90s, 99% a decade ago with RF. Even if we let this surveillance this patient a little bit longer, as Dr. Ball might say, I can still salvage this at 2.7, 2.8. But no, as the guidelines stress, over 3 centimeters, we should not have a wait. We lost the window for an ablation. And that goes for cryoablation, also for a series over a decade ago and over 10 years of data. At WashU, same thing, size matters. This case that we were debating was teed up for me because this patient sits at 2.5 centimeters, the perfect patient. And UCSD in Tennessee did the same thing. T1A tumors, 4-year follow-up, multivariate analysis. Again, size matters, and this patient is, again, a perfect candidate by size criteria for thermal ablation. Now, the next question we want to discuss, of course, is oncologic efficacy. There are series in the literature. This is a retrospective SEER database, but I like this study in the sense that it's over several thousand patients, 7,000, 8,000 patients, and the disease-specific survival after surgery versus a thermal ablation, disease-specific survival was a 1% difference, 98 versus 96. I would argue that that is acceptable and does not argue that partial nephrectomy is superior. I would say that's some phenomenal result in the literature. And as such, the guidelines have endorsed that this is an alternative treatment. Now, the other thing you might argue for is that this is a young patient. He's 55. Those of us in the room, including myself, who are about that age, I'm 56, would be concerned maybe, should we do a thermal ablation in a patient who's so young? And the answer is we can safely. The tumor and the ablation and surgery doesn't know the age of the patient. It's the efficacy and the treatment selection, patient selection that matters. In the perfect type of patient like this, Jeff Gahan, again, almost 10 years ago, clearly addressed this issue. We looked at patients, mean age 57, 2.2 centimeters, 5-year follow-up. In the 5-year and 10 years, disease-free survival was 94%, and overall survival 96 and 91. What I want to take home here is the overall survival is kind of a little bit scary at 56 years old because I have an 8% chance of dropping dead in the next 10 years. And that is no difference if I had an ablation or if I had a partial nephrectomy or if I had nothing done. So the disease, we are not compromising patient outcomes in a 55-year-old man, as this case is, in terms of offering them ablation. Their chance of dying of anything is exactly the same if I did a partial or if I did an ablation. The morbidity is obvious. We can all quote literature, but again, I'll just go to the guidelines which say that there's a favorable morbidity profile to surgery, period. You can't tell me the transfusion rates are lower with partial nephrectomy robotically. Hospital stay, we're talking an outpatient routinely, and the conversion to radical nephrectomy with partial is real. And so it's a no-brainer that the morbidity of a needle ablation is easier. And what about this question? I just made the case that the oncologic outcomes are the same. We heard Ryan say that we have this issue with salvage and there might be a risk. Just like you guys spent the last 2 days talking about prostate ablation, yes, there is a small chance of incomplete in-zone incomplete ablation, much less than in prostate cancer. But if you recognize the fact, like you make the case with prostate cancer, that we can salvage these patients with a repeat ablation, the oncologic outcomes, the disease-free survival is no different. So we can't change the game with this tumor, which is a visible tumor, easily targeted. We can easily salvage with another outpatient 1 hour, hour and a half procedure versus surgery. So, and then the last thing, I get to go last, so what about active surveillance versus thermal ablation? There isn't a whole lot of literature, but I would argue that these are very well-respected authors, You can read them here, and they looked at a population-based assessment of ablation versus surveillance. And in about 1,800 patients over the first decade of ablation, so 2000 to 2009, not a SEER database with all its problems, they looked at the 5-year cancer-specific mortality. And lo and behold, it was higher with surveillance than ablation. So I'm going to use this to make my point, and I'm going to use this to say that ablation will offer patients security and slightly better security, that they won't have that rare metastatic progression that Brian brought up that can happen, because I'm going to take care of that risk by doing an ablation and reducing their mortality rate instead of observing the patient. And finally, what about parenchymal volume? What about renal function? I'm an author on this, but I really just contributed patients. Saul Waldo and Jim McKiernan's work at Columbia looked at volume average thermal ablations versus partial nephrectomy. Take-home point is thermal ablation resulted in less parenchymal volume loss than what I would argue are expert partial nephrectomists. And thermal ablation resulted in less GFR loss in these patients, which were, again, computer volumetric analyses. So at minimum, there is no difference between ablation and partial nephrectomy. So to wrap up, we mentioned durability already when TJ talked, so I'll skip this slide. I just want one last point I want to bring up in terms of the argument for a needle biopsy. Needle biopsy ahead of an ablation probably does make an impact in terms of patient selection, because it does influence success. And the main driver here is papillary tumor versus clear cell. Papillaries are hypovascular, as we all know, compared to clear cell carcinoma, and thereby, with thermal ablation, less heat sink, higher success with both RFA and cryoablation. The driving factor in success is tissue type, so I endorse the concept of doing a biopsy. There is no difference between RFA and cryo in the guidelines, and so there's no difference in institutional series between the RF and cryo, and that issue has been settled. We already heard about microwave and IRE, so I'm not going to say more about that. We just need more data, but they're going to be real. And so I think I made my case that we have good oncologic data, we have good nephron sparing, it's definitely less expensive. It reduces the risk of metastatic progression if you do active surveillance. And tumor size, we know, makes a difference. This is the perfect case, and we know histology probably makes a difference. And the only thing I would add is we could biopsy this patient if we wanted to. Thank you very much.
Well, great. I think everyone gave a great case for their modality, and I think it really comes down to patient choice and selection. But Jeff, you're absolutely right. I mean, I think in 2023, if you're not offering ablation as an option, you're not giving the patient the full spectrum. We have time for a couple questions here. All right, great. Happy Saturday, everyone.